those surgeons that are maybe general surgeons doing maybe one lumpectomy a week or one a month or whatever it is, now they've got this tool that helps them get better, even though they're in a small rural hospital with a very low population. So that to me allows us to bring that sort of care out into folks that just wouldn't have access to that where they are, and helps every surgeon sort of up level themselves and feel more confident about the care they're bringing their patients.
If you're a long-term listener, you've heard me kind of joke about how, I'm not cool enough to be a surgeon and this and that, couldn't scratch my nose in an OR and I'm a baby and therefore I couldn't do it. I'm always joking because surgery will always be, I think, at the cornerstone of cancer management, and also something that's probably much further away from being replaced entirely with AI. Like robotics and stuff is more distant than algorithm-based stuff when it comes to treatments and treatment diagnostics. With all that said, I'm super excited to have someone that is also kind of playing in the surgery sandbox far more than I am, because he is a tech guy, and that's just an understatement. I mean, he has deep insights on everything that technology can do. He was actually the COO of Grok with a Q, and I know Grok well because I would listen to the All In podcast all the time. And Chamath, I think, was one of the, principal Series A's funders. So our guest today has a litany of experience and has a passion that I want to unpack and uncover on really just his recognition that surgery, which is such a core element of so much we do, can actually be significantly, potentially, improved, cleaner, and even cost-effective than it is today. So with no further ado, we have Adrian Mendez joining us to be able to talk all this out. Adrian, it's good to have you.
Yeah, thanks for having me, Sanjay. It's great to talk to you today.
Yeah, likewise. So tell me, with all the experience you've had, as I understand it, Grok is kind of competing in the kind of chips it provides to power, a lot of this stuff that is required to be able to have the kind of wild, efficiencies and everything that AI brings us, because there's obviously, electricity, so to speak, to anything when we were talking about tools. How did this bring you into the world of surgery? What did you recognize was missing, and where you kind of thought maybe there's some solutions here where AI in my Silicon Valley or, West Coast world traditionally thought can really improve these things?
Yeah, I mean, your introduction was exactly right. I was at Grok for many years, joined them shortly before they were founded. Jonathan Ross, who was the founder of that, was an engineer at Google, and had done some work over there. And then he left and started this company. And so I've been in this AI space since early 2017. So, not as long as some people, but longer than a lot of people. And so really got to see it develop before large language models and ChatGPT was a thing from the early days. And so super exciting just seeing a brand new technology emerge from the depths of scientific, research into something that everyday people can use and see it really touching their lives every day. And I was working on a very low level, hardware, computer chips, compilers, very engineering type stuff. But then to see that go from that early days into a point where everyday people can beat it was super exciting. And so when I had the opportunity to be introduced to Perimeter, for me, that was very exciting, because for me, this industry is several years behind, obviously, where the hardware, computer hardware industry was with respect to, and software industry was with respect to AI. So going through that journey of a very small number of people doing very cutting edge stuff, and then slowly getting it to the masses, which is what we did at Grok, and they continue to do. For me, that's super exciting to do that journey again in a brand new space. And what was exciting to me about healthcare specifically was that everyone can relate to that, right? Especially breast cancer. Computer chips, it's a little bit hard to get emotional about that. It's a little bit hard to tell your 13-year-old daughter, 14-year-old daughter how cool that is. But healthcare and breast cancer, everyone can get, has a personal over. So for me, this was very, very exciting to join this company after being in the other one before.
Yeah, for sure. I mean, we had Dr. Azra Raza from Columbia talking about how, her hopes one day is to really just like eliminate cancer altogether, right? And in the sense of early catching, but that's quite distant, at least in the scalability of cost. So the next best thing is to be able to not even have to leverage the tools of, sequencing and precision and all these insights with systemic therapy and chemos, ideally, and we're seeing that, about a 1% increase, I believe, in the quote unquote cure rates, annually for a long time now, when it relates to being able to cure cancers, which oftentimes requires it to be early, right? When the cancer is growing and before it spread off somewhere that a lot of times we can't even visualize. But to that same effect, in colorectal cancers, possibly an example, some of the ones that you just kind of classically think about removing, which are different than prostate. I mean, prostate, you just take out the prostate for the most part, right? But in breast, you're trying to conserve. It's called breast conservative therapy. You don't want to take out any more than you have to. And I believe, and I'm sure some of our listeners know, that there's a problem with what is, number one, said we got it all, and that was just the thought, and it turns out that there was something locally that was still there. But number two, where it's, we thought we got it all, realizing we didn't get it all, and then going back and having to try to get it all again, which has its own holdups on already an overstrained or exhausted system where there's not enough oncologists and surgeons. So I believe that's the kind of space that interests you, right? Is like, let's just make sure whether it's found out that, shortly after that we need to go back and do some more. That's the ideal scenario between the two, or found out just way later, which is like really unfortunate because you went all that way and just kind of left a little behind. That's where your kind of passion and interest is. And I believe where your mind is saying, hey, there's some tech that can really help here.
Yeah, that's exactly it. So, depending on the type of cancer, we talked about breast cancer specifically, approximately 1 in every 5 women who go through a lumpectomy has to go back in again for a second surgery, which is horrible. Strains the system, costs money, but worst of all, that patient and that patient's family now, has to go through the entire ordeal again. And especially when the hopes were that this, going, into the first surgery, that everything would be better on the back end of it. And it isn't. That's just a complete reset of expectations, and it's horrible. So, if there were a way to help reduce that, that would be wonderful. At Perimeter, and this is a really interesting thing about the AI technology. So at Perimeter, what we've done is we've taken 2 different types of technologies and put them together in a way that can help address this problem. The first type of technologies are imaging technology, which is called optical coherence tomography, or OCT. So OCT is used in many different applications. A couple of them are for optometry, for scanning the retina. Almost all of us have had that, when we go to the eye doctor. And for vascular applications where they look, inside veins and arteries, it has very high resolution, which when you're trying to ensure that you get clean margins after the cancer surgery, you're really looking for, cancer at the cellular level, which requires a very, 10, 20 micron type of resolution to be able to see that. Super, super fine. Very, very much smaller than X-ray or MRI or ultrasound or whatever. So,
and much smaller than the naked eye, like in the
much smaller than the naked eye.
Yeah,
exactly. So you've got this surgeon, world-class surgeon, who, through no fault of their own, really struggles to get these very clean margins. So how do we bring tools to them? Okay, well, this OCT imaging technology can help because you can see at this level, and that's been available out there. What Perimeter has done is be able to take that general technology and make it more applicable to cancer surgeries, right? So we've been able to increase the field, like the size of specimen we can look at. So you take a tumor out, it's several centimeters by several centimeters. We can scan that whole tumor and scan into it a few millimeters and look at those margins. Okay, wonderful. Now you're in a situation where you have a surgeon who you're asking to almost learn how to be a little bit of a radiologist, look at these images, try and interpret what you're seeing there, and based off of that, make your own decision as to what you ought to do with the patient is still laying on the operating table. There's a subset of surgeons that are willing to take that on and to do that work. But the great unlock is if you could somehow bring an assistant to that technology, to the OCT imaging technology, that would make it more accessible to many, many more surgeons, right? And so the analogy is a little bit like, what's a common one? Autonomous cars, right? So most people can drive a car, but if you're too young or you're too old, then it gets much more difficult to drive the car. However, if you had some way, some software, some sort of technology can help even those people drive the car without having to be tall enough or reactive enough or whatever, Wouldn't that be wonderful? Because now you bring that car technology to more people. And this is the magic of what I saw when I joined Perimeter a couple years ago is, wow, we could bring this OCT technology that can really enhance the surgeon's ability to detect cancer in the margin to many, many more surgeons, because with an AI assistant, it makes it more accessible, which is just better for surgeons and better for patients.
No, for sure. So, to your point of sometimes looking at images right after the surgery, or, another strategy, depending on the cancer type, is sometimes to do like a bedside frozen to make sure, like, to get a good gross, quote unquote, no pun intended, or maybe, idea of kind of like what that margin is if I keep going. Because again, to the whole effect of trying to resect as little as possible. But these revisitations, I mean, 1 out of 5, anyone listening that had a revisitation, I mean, it's not, not mean to scare anyone, but in an ideal world, it's a little bit extra scar tissue, a little bit of, going back and finding it. A lot of times things are inked to even like know where they are and then have to like relocate. So there's a lot of downstream things that's not as technically clean as one would think to actually finding that place. I mean, the whole tissue with gravity, after breast cancer specifically, has kind of changed, conformed, and kind of settled, right? After the lumpectomy,
Yeah.
and now you're going to go find it in a landmark that's tectonically, shifted or changed. So this technology, one, helps with the imaging and but bedside. So like you're doing this, you're taking out the specimen, and I love that you said it gets a couple of millimeters in, because if anyone listening doesn't know, what you're doing is you're trying to appreciate in a 360 conformational way, is there any area of this that is still invasive cancer? Meaning that, that's what makes a DCIS, meaning a stage 0 breast cancer, stage 0, because it's not invasive, carcinoma in situ, versus a stage 1, which is invasive, which means it's invading the tissue. So if you could look into the tissue immediately and appreciate at a very sub-eyeball level, meaning you can never appreciate with your eyeballs, obviously, still even deeper than that, a couple of metrics we use today, that it actually is able to kind of, I don't know if there's a number or percentage, but with a high degree of confidence or aspiration, be able to say, look, this is all free and clear.
That's right. Yeah. Yeah. And we've started to gather some data. We've had a little bit over 1,700 patients now go through, with surgeons using our device to date. We have one device that's cleared on the market today, initial device. Now, this is remember I said there's 2 types of technology that we put together, the imaging technology and the AI technology. So what we've got FDA clearance on today is the non-AI version of the product, which has the imaging technology, right? So we have surgeons using that.
But sorry to interrupt you, but you said now in breast cancer. What else is it used in, or is it predominantly breast?
Predominantly breast, although the clearance is for any tissue type. So we have worked with head and neck cancer surgeons, and we've been able to capture images. And if you think about sort of the pathway from where you have an idea that, hey, maybe this tech will work on a certain type of cancer, to, yep, it works and we're ready to go broad. It's sequential, right? We find a surgeon who's interested in figuring out how they can use something like this possibly in their practice.
Sure.
We then partner with them. We'll put one of the machines in their operating room. We'll start to scan the tumors as they come out of the patients and collect a whole bunch of images. And it really starts with collecting pictures, right? Collect all these images. Then the next step is, okay, can we correlate at a human level, correlate what we're seeing on the screen to what pathology comes back and says that they see under the microscope? And if we can start to make those correlations, then we know we've got, we got something
here. Yeah.
That's right.
I mean, I'm thinking about those debulking surgeries too. Like ovarian is very common to just debulk, like take out as much as you can in the peritoneum. It can still be stage 3, even if it's in that area. So, rather than I think I got it all, or primary, mesothelioma, which unfortunately, one of my long-term best friends has, it's kind of just that I think I got it all, gross inspection. But to be able to actually look at it and say, wait, that one, that right there that you just pulled it from, XYZ, where it is, try to, get some more just out of due diligence. That sounds pretty crazy. And amazing.
Yeah. Well, what's even cool about this, especially with breast cancer, and lumpectomies, is the goal of lumpectomy is to take out the cancer, but to take no more tissue than just what, is the cancer. You don't want to move into a mastectomy mode, and that's why the woman chose that sort of risk trade-off.
Yeah.
So what happens frequently right now, as you know, right, is that surgeons will take proactive shaves frequently when in a lumpectomy, just to try to make sure, they'll take as much as they think is right, then they'll take a little bit more to try to increase the odds that they get it all. But many times that's not necessary, right? And if they could have left that tissue back in the patient, that's better for the patient, better for recovery, better for everything. But there's a trade-off there, right? Do we take less or more tissue? What's the risk trade-off the surgeons make of getting all the cancer or potentially leaving some behind? The potential with our technology is you can be a bit more precise. You can take just what you think in your first, extraction, first resection, and then scan it, and then look, and then say, oh, wait a minute, I think I'm a little bit short here, and I'll just go and take that one margin or those two margins, but I won't take the other 5 or 4 or 5 margins.
Right.
So you get much more precise, and the idea is then the surgeon feels better about the work that they've done, and they walk out of that operating room with some sort of confidence that they didn't take too much, not too little. They're not super nervous. Of course, they've got to wait for pathology to come back, but there's a little bit of confidence that they've got going into that.
Yeah.
And then the patient goes home feeling like, okay, I'm feeling pretty good. The surgeon's feeling pretty good. And, knock on wood, when the pathology report finally comes back a week later, it's a successful surgery.
Yeah. So this is the AI free part. What's the one that includes the AI?
So the one with the AI, okay, so today with the AI free part, all of that happens. And then after the specimen scanned, the surgeon's looking on the screen, sort of, remember those old flip book movies, like a bunch of pictures and you flip it and it looks like a movie? It's kind of like that, right? So they're scanning through all the images, thousands of images, looking for things that look suspicious. And they're trained on what looks suspicious. What the AI version coming out will do is we've got a model, we've trained it. We have a pretty big image library, about 2 million images right now, our image library. So we've trained the model for that. So now what happens is while the scan's happening in the background, in the machine, all locally, all the data is kept local. The algorithm's running on all those images. And it's highlighting the ones where there's the highest probability of a suspicious feature being identified. And it pushes those to the top of the screen, right? So now as a surgeon, rather than having to scan through 6 margins, a couple, 30, 45, 60-second scans through every margin, you get half a dozen, maybe a dozen images that you look at, a little thumbnail. You click into it, you inspect it. Maybe you scan forward and back a little bit around that place. So what does that do? It does a couple things. One is it improves the time. The idea is now you're spending less time scanning all the images. It reduces the mental load of looking for what we call the needle in the haystack, right? You've got an assistant there giving you their sort of opinion, but eventually it's still, the control's still in the surgeon's hands. They can disagree with the opinion of the AI or they can agree with it, but it's eventually their decision. They can see everything the AI sees, right? So they're not handing decision-making power over something else. They still retain all of that power to make the right decisions. So for those surgeons that, are using it, it'll have that improvement. But for me, the thing that's more exciting is for those surgeons that we introduce it to and they're like, that sounds intimidating, right? I've got to look at all these without the AI. I got to look at all these images. I got to train myself on how to look at this stuff. Oh, you now have AI? Oh, this is not so intimidating. Let's give it a shot. Let's take a look at it. And it really, we think, we actually, it looks like it's going to really open up the market adoption of the product, which is obviously good for us as a company, right? It's good for the patients that are in, the hospitals that we already have surgeons. But even more exciting is now, what does this do for those surgeons in community hospitals, right? Those surgeons that aren't only doing 3-4 breast lumpectomies a day, 2-3 days a week, right? Those surgeons that are maybe general surgeons doing maybe 1 lumpectomy a week or 1 a month or whatever it is. Now they've got this tool that helps them get better, get closer to the level of the folks that are sitting in San Francisco or New York, Boston, San Francisco, whatever, Dallas, even though they're in a small rural hospital, with a very low population. So that to me is exciting. That to me allows us to bring that sort of care out into folks that just wouldn't have access to that where they are, and helps every surgeon sort of up level themselves and feel more confident about the care they're bringing their patients.
1,000%. So you're saying that it helps the access to care in the sense of not, I guess, necessarily getting the surgery, but getting the effective surgery or for the purpose that the surgery is being performed.
That's right. And you can kind of see some of that in data. The rates of second operations because of cancer left behind tend to be lower with those surgeons who do a lot of breast cancer surgeries, and slightly higher for those that don't see as much. And I mean, it makes intuitive sense, right? The more you practice, the better you get at it, the better radiologists you have in your facility, placing a locator, the better imaging technology, the more frequently you can talk to the patient because they probably live relatively close to your facility. So it's some of the patients live far away, so them coming back for a second surgery, it's not easy. They have to travel many miles. Oftentimes they might have to find childcare, which is tough. So I think this, and this is just, I mean, I'm talking my book a little bit here because it's what Premier is what we do. But more broadly, this is what I see. This is what makes me excited about AI and bringing it in general to this industry, especially because it does provide much better service. I believe it has the potential to provide much better service kind of across the spectrum if you can bring these tools to bear.
Yeah, we had a very interesting or eye-opening episode with Dr. Michael Byrne, who is an endoscopist with colorectal and GI surgeries. And he was saying it's not even necessarily like the doctor can be really good, but if they're in a predominantly Caucasian area, and we know that people that are of a certain ethnic background have a certain curry diet, like in Indian culture or Jamaican, that these, sketchy lesions just look different and the mind doesn't know what the eyes haven't seen. So the research shows that these things can be missed if there's anything that's different than the kind of norm that you're very well trained on seeing. And so with that AI technology, you can say, hey, when you put in that stuff beforehand, they're on metformin or they are vegetarian or whatever, the gut, in its own features, would have things that look suspicious appear different, and it just kind of clues you in at the same time. So to that same point, I would love, especially your probably unique insight on this concept of data, like where, how important, and I've always alluded to this in several episodes, is it like to the degree of really turning the key on this kind of insight? Like in this case, with the margins, I'm sure, are you feeding of those 2 million images you have, pathologic or pathology assessed confirmation or lack of confirmation that it actually was in fact positive margin or negative? That takes 2 pieces of data now. It's not just the picture, but it's actually the outcome, and that's what's called outcome data. And I know there's a lot of still kind of fear of people just saying like, well, I don't know if I want to share my data, etc. So 2 questions. Number 1, how important and key is data in this process of being able to get better outcomes when it comes to surgeries of cancer, seemingly of any kind? And number 2, what are some of the holdups or challenges you see, or things that need to be done so that we can kind of get these kind of insights when it relates to data?
Yeah, great question. So, the way I think about AI in general, so I'll just step back a moment to give context and dive into the data question. So AI is really, there's 3 components basically when you think about AI. One is the hardware, the NVIDIA computer chip or the Grok computer chip, or the hardware that this is all being trained on and then inferenced on, or you train a model and then you use the model. Okay, there's the hardware piece of it. Then number 2 is the algorithms, right? Every day you wake up, there's a new algorithm. There's ChatGPT 3.5, 4.5, or whatever. And then there's the data. So the hardware, there's a few companies make the hardware. It's hard to make hardware. It's expensive to make hardware, and that's happening. The algorithms it's kind of a commodity now. Like, they're open source. We've seen DeepSeek, for instance, come out of China, being able to be created very, very cheaply and trained very, very cheaply. So the algorithms aren't really the moats that once upon a time they used to be, right? Anyone can go onto an open source software repository and pull an algorithm, and some amazing algorithms. So it comes down to data, the third component. And this is where the gold is, right? The data. So you can have the best algorithms and you can have a little bit of data, which makes the AI be kind of smart, or you can have a lot of data, which makes the AI much smarter. Or you could have lesser data, but high quality data, which then allows you to get smart algorithms with much less costs money to get data, right? So much less cost. So
Most dilution.
okay, so that's a framing up the whole thing. Now for us, and I think for healthcare in general, what you if your ChatGPT gives you a bad answer, yeah, okay. You do a little bit more research, you realize that it hallucinated again. But with healthcare, it's a little bit different, right? So you want to have some pretty high quality data. So our 2 million images, they actually come from about 200 patients. So not a lot of patients, but every patient you get a bunch of images from. And all of that is correlated against pathology, right? So one thing to remember is most of the images you take of a lumpectomy is healthy tissue. So that correlation is pretty, you don't have to label it. Where it gets interesting is where you have to label it. So there's a subset of those images that are, that have cancer, right? That the pathologist said there's something there, which we label. So that's key. So what do we want to do? We want to greatly increase our database. That'll do a couple things for us. That will allow us to identify different types of cancer features, right? The more data we have, the smarter the algorithm, the smarter the same algorithm we have can get. The more data we have, the simpler we could make the algorithm, or there's other modification we can do to the algorithm that makes it run quicker. That could make it run, if it's smaller, it could run on potentially cheaper GPUs, right? So the hardware, the whole device gets cheaper in the operating room, which is always very good. The more data we have, you alluded to this earlier, which is spot on. Every person's different and unique. And there are classes of people, right? So with breast, there's dense breast, there's less dense breast tissue, ethnicity plays a role, age plays a role, extent of disease plays a role, whether it's DCIS or IDC or lobular, or mimickers, right? It's not everything's cancer. But the more data we have, the better we can distinguish that. And it's a continuous process. So now, how do you get the data? We have I'm going to call it a camera. We've got our OCT imaging device, our camera, our OCT camera. We're the only ones that can take this picture. So we have to collect all our own data. We can't go and buy it from a database, which means we have to be very close to our hospitals, our surgeons, through them, the patients, to be able to use the data through an IRB. Everything has to be very controlled. But the more we can bring into the database, the better we can get there. What our position is, and we hope, our job is to convince our, partners for this, and I think we'll be successful, is, hey, look, the information we're gathering is, first of all, it's de-identified. We don't care about the person's name. We don't care about, their economic demographic. We do care about their age. We care about their ethnicity. But then the pictures we're taking are, quite frankly, the inside of your body. I don't know, me personally, I don't care that much if you take a picture of the inside of my body. It's not my face. It's cool. So there's that. And then the angle that I think is very, very powerful, because you see such community in folks who have gone through cancers. Hey, look, if we can do this, we can make our machine work better. And if we can make our machine work better, we can help all those patients are going to come after you, and you can be a part of that, right? As it gets better, you can be a part of helping some other patient not have to go through a reoperation, or helping save the system costs later on down the road. And you'll never know those patients, right? Because you don't. But that's a little piece that you can provide. And so, and that's powerful. And that, I think a lot of people connect to that. Hey, if I had to go through this, it's the worst thing in the world I've had to go through in my life. I'd really like to make it easier for others not to have to go through the same thing. So, just to summarize, data is very important. The more data we have, the better we can get, the cheaper we can make it, the faster we can make it run, and the more precise we can make it. And that has all the obvious benefits.
100%. And, it didn't take me long into practice that I just hope anyone listening that hasn't gone the medical track can appreciate is you go in for a reason, a purpose, often ethical, compassionate, moral. And fast forward, the quickest you can become an oncologist, starting pre-med is 13 years, right? It was the fastest, 14, something like that. And then within, very quickly, when you start asking, oh, why not this? Why don't we do this? How come not this? You realize it's all comes down to cost. Like bottom dollar talks, unfortunately, because it is the system that's not a social system. And I don't have an opinion either way. This is a reality. So when I'm thinking about something like this and tools like this, the thing that immediately comes to mind is, and if you don't know this, you do now, but you probably definitely do if you've listened to any previous episodes, is insurers or payers, health insurance company, etc. They're the ones that really determine what does or doesn't fly, for the majority of us.
Yeah.
And what I can see is the argument, and I'm sure this is maybe the primary angle, is, hey, check it out, payers. We can save you money from having to do another OR cost and another surgical, specialist cost and the anesthesia cost and everything if you adopt our equipment. And you're saying all this to massage them, but ultimately like to give better patient care, right? Because I can't imagine how scary it is, especially in a rural place. I mean, it could be weeks by the time you get back in. And in your head now, the psychology of there's weeks with, persistent cancer, to where ultimately if everything would have ended up the same, even if you needed adjuvant chemo or treatment afterward to reduce your chance for the disease you cannot see, because it takes 100, 200 million cells to see it on a CT scan. It's thought to be gone, but that's why we do adjuvant. We know the people that still have something somewhere that just cannot be appreciated in modern day. Imagine the psychology of that recurrence coming, even if it would have come either way, but your revisitation to get that additional tissue out, took 3 or 4 additional weeks.
Yeah.
Now the patient, the family members, if something is a very bad outcome for the patient, will always wonder for the rest of their lives, like if they would have gotten it all the first time, even if the outcome would have been the same. But to me, the psychology of that is huge. But those are all the things that can come. And unfortunately, or not unfortunately, just say is what it is. For things to get better and have improved outcomes psychologically, clinically, everything, there has to be a dollar argument. And I believe that maybe this is the case here. And, we've never really talked about value-based care models too much on this podcast. Deborah Patt is very good on that. She's the ASCO chairperson for the AI Task Force, EVP of Texas Oncology. But basically the thought and concept behind it is, what can we do? One, you kind of pay up front and just have an X amount of money that you're able to utilize. But even if it's not a classic VBC, the concept is, how can there be a value add for something that may cost something up front, but actually end up saving a lot of money, for at least in this case, the payer. Anyone listening needs to realize all the systems are different, because a hospital system and a doctor, me being a doctor, does get paid for more. Now, are they purposely leaving margins? No, because there's no shortage of business when it comes to cancer. I mean, like, you want to help. I believe that's preserved. People want to help as many people as they can. Let's pray that that's the case. But that's where it gets complicated. And this is where something I think can help everyone, because the patient benefits, the payer in the system to get the patient to be able to benefit. And then also, institutions and doctors can take care of more people, because we're very aware of the amount of shortage there is for cancer care. So when it comes to the cost savings, or I would even say the strategy on having patients be able to benefit from something like this, to get it all the first time, to not have to wait, to not have to stress about it, would there be, or is there an implication on how this technology can help economically, which downstream means hopefully, a reduction in this rising cost of healthcare, getting insurance, the bills that we get? How does this play into the economics of the healthcare system as a whole?
There was a study that was published a year ago, or in 25, maybe a little bit more than a year ago, put up by a few researchers from MD Anderson. Which was an economic study. So it was pretty broad-based. It was looked at several years worth of both Medicare and commercial payers for breast cancer, thousands and thousands of records. And looked at, okay, what is the cost? The extra cost of all of these re-excisions that are happening across the country. And when you kind of go through the math, you crunch everything, for every re-excision is somewhere like up to $25,000 to $30,000 for a second, surgery, not including, and now if you have to flip over to a mastectomy, now you're talking, tens and tens of thousands, 50, maybe close to 100,000 extra dollars for that, flipping over to a mastectomy. So yeah, as humans, we think a lot about the emotional response, and as surgeons, I'm not a surgeon, but I can just imagine what it feels like to want to help someone to do a job, and then unfortunately it doesn't work out the way you hope for. Like that's got to take a toll on you as a provider. But then if you look at it from as an economic animal, then you look at it, it's like, oh my goodness, we are wasting hundreds and hundreds of millions of dollars every single year due to this. And that's terrible. And probably the most egregious part is, what you said is if you leave the cancer there and it continues to grow for 3 or 4 more weeks, 5-year survival rates go down, right? And for breast cancer, they go down some amount. If if the first surgery was successful or not, but other cancer types, it goes down quite a bit actually.
Oh my gosh,
5 year
like
survival.
progressive pancreatics and things that I can't imagine would be very, timely.
So, so this is so the economics, and you're right, bang on the money, right? So who cares about the economics? It's the payers, right? The insurance companies that really care about this. And so part of our job is also to gather that data, which we've started to do, and present to them and say, hey, look, not only is this in the best interest of the patients from just a human level, but it's also in your economic best interest, because, by the way, you're paying for these second surgeries, and you can't want to be doing that. And not only is that direct cost there, but if that operating room is occupied by doing that second surgery, then that operating room becomes a scarce resource. And if you've got more supply, less supply and more demand on that scarce resource, the price of that operating goes up. So what knock-on effect is having across everything else you're paying for, because there just aren't enough operating rooms? So there's direct cost, and then there's all the indirect costs. So, that is starting to resonate we've started those conversations, but it resonates. It doesn't take a complicated logical leap to go from what we can solve to the ability to save money in the system. And if you go through that analysis, it's hundreds and hundreds of millions of dollars. You can bring that, not even bring re-excision rates down to 0, but just cut it by 50%, 75%. It's a ton of money you can put back into the system for sure.
One place that I'm thinking out loud, there's hard to find a cancer that most would agree is the most kind of sinister and challenging, and that's glioblastoma multiforme, GBM. And the reason for that is it's never nicely encapsulated, it's never prettily round. The way that it behaves is kind of more injection based. Like, it's just like, I had a staff member that said if you put black ink and just kind of sprayed it into a tissue box, there's going to be different depths if you sprayed it a few times of how many tissues go where, and you can't resect that much brain, obviously. So the best we try to do is resect the bulk of the tumor. And because we know that they're injections, you kind of, give radiation afterwards, oftentimes in the bed or the area, hoping that the millimeters of penetration you didn't resect because it's too costly will be taken care of. We even actually had a podcast where we talked about an implantable radiation device to really be able to address the bed of it. But one extension that I'm thinking further is if you were able to, say you even had maximal resection or close to maximal on what you're comfortable with, I could see how something like this bedside will say, well, look, let's just at least take note of where this extension is most positive to hopefully boost some additional radiation to that area, in addition to the, just the general coverage amount that's going to be in the bed, as well as possibly, a lot of times they do these surgeries where the patient's kind of awake, doesn't feel it, but awake, because what area is going to be affected. So if somebody can do math or not in a certain area, or someone can sing, or someone can do memory recall, those are things you evaluate in real time as you're resecting, which is wild. But then at least what direction, because you're in there, because it's happening, because the cause has happened, to be able to say, if I can resect more and still preserve, you're going at a depth that's further, pun intended this time, than just what you can see or do on a frozen. You can actually hopefully see to a greater extent. So these are kind of the things I'm just thinking out loud on that, and the debulking surgeries, the things where you hate to, quote unquote, go back in again. And especially, even though not just for curative intent, but close to cure, or at least to improve the progression-free survival, in those cases where maximal resection shows a direct correlation with either progression-free survival or even overall survival in certain settings. So, again, thinking out loud, but this is where things can I think make sense, and hopefully
it's interesting when I'm an engineer, not a doctor. But what you were describing with that kind of, is it similar to DCIS, where the DCIS travels along the ducts in sort of like spindles and can go pretty
Yes,
far in a very
exactly, but
localized.
with no ducts, right? Because it's the brain. That's why it's so hard. Is because
Oh,
it's all invasive. But to your point, like that yes, it's like you don't know the trajectories and how much that extends because you're not going
yeah,
to take a thin line, right? That's spindling somewhere. You're not going to take out all that brain tissue because it all
right.
has like very like consequential pathways. But then if you're able to actually get an idea of even the serial pictures and images of the reduction in that, say in that diameter, then
Yeah.
hopefully that can help you appreciate how thin or wide you can with, especially with an AI component of predicting how far does this go? How thin can you get on a resection? I don't even know if you can cut out a little sliver deep wise. I'm not a neurosurgeon, but these are this debulking peritoneal tumors. The liver is generally generous because there's a lot of it and can kind of grow back. So that maybe they kind of just hack away at that. That maybe that's less relevant. But thinking out loud, this is where those kind of things are important. And then when you really talk about things that invade important factors that we consider on risk, and by that I mean microvascular invasion, meaning like the small blood circulation. You don't like to see a tumor in there. Lymphatics. I'm sure you can build and really start considering those things as well on the things that we know are risk features that are structures that these cancers are invading on. It would be great to, even if nothing else, have insights on what resecting more or less or where the circulation goes, downstream on recurrence rates could potentially lead us.
Yeah, I mean, just the ability to have something in real time where you can have this imaging, I, it almost changes, I would think, the paradigm of how, as a physician, you would go and do your work.
Right. Like it could
Oh,
be guideline changing because like a lot of times we just have snapshots. But to
yeah,
our point earlier, when you have the continuous data of what was a local recurrence, what wasn't, was it in the same area that this microcirculation actually dumps into, aka, for example, the liver. Oh, it turns out you're seeing more liver mets. Like all of this can actually be longitudinally and over time really kind of considered and give us a better predictive index, which is AI altogether, right?
yeah.
Of what to anticipate, what precautions to take. Should we be changing the way we do adjuvant? I'm just thinking out loud, but it really opens the door on stuff that otherwise we just say one and done in a binary way. Microcirculation is present or not, lymphovascular, invasion is present or not, and we're just kind of done with it, and that just guides us. But what if we can actually think about where these recurrences happen, and if that area is relevant, do something about that area? It could
Yeah.
be in that sense guideline changing.
It's so, one of the most exciting things for me that I've seen with the surgeons use our product is using it in ways that we never thought of. So we approached it from, okay, within the breast surgery sort of area, lumpectomies, right? But we've got surgeons who are now saying, on their own sort of recognizance or whatever, say, hey, I wonder if what we can do with this is use it for nipple sparing mastectomies to look at the underneath, the underside of the nipple to make sure we got everything there. And if not, do some extra work. Something that was not really in our viewfinder, so to speak. But that's cool. That's cool, right? Like as as an engineer, bringing a tool to users of the tools and then seeing how those users of the tools use it in ways you never would have imagined. And then once they come back and say, hey, we started using it this way. What do you guys think? Can you tweak it tweak the tool this way or that way, or train the algorithms better in this thing or that thing? Then that gets us super excited, right? Because then our engineers are like, oh yeah, we see the juices flowing, right? They're like, ooh, a new problem to go solve. And then they start digging into it. So I love these types of conversations where, like what you just did, right? Like, I wonder if something like this can be used in this new manner, which we had never thought of before. It's like catnip
Right.
to a
Yeah.
bunch of engineers making something like this.
Yeah. I mean, when you talked about the nipple sparing process, which is a very interesting one, I'm thinking about also head and neck and ENT. You had mentioned head and neck, of course, because they're such important structures. But even in the ENT, you have these wildly specialized surgeons that have to go into this midbrain area and other areas that are just so intimately and closely related that you don't want to take off a sliver more than you have to. Now, on the flip side, you know, this is the beauty of AI. When an experienced surgeon says, I just feel like there's probably something there left or it's still there or whatever, if the guidelines say currently you just watch it and then, cause an issue when you have an issue, these are the things that can open up trials, because if you know there's a margin, then you can ask the question and potentially do a trial that says, should we be delivering, adjuvant radiation in that area at a boost rather than a general, lighter sunburn, whole area? I mean, all of these things can be uncovered and need to be. I mean, that's the frustration that I learned through social media that was at first, my feelings got hurt or was offensive. And now I'm like, I get it. They're like, how come we're not doing better? Like this whole cancer thing, like, why is it such a problem for decades? And it's because like, it's just hard to tease apart all of the nuances. But when the aggregate of all of the nuances are the way, at the end of the day, the problem, you have to.
Yeah.
And you couldn't before because you couldn't do things in parallel with 5 different nuances or variables in one specific case and then be able to crunch and analyze it until you have neural networks and being able to do things like, multi-layer processes in parallel and shut off these and turn these on, and these seem to matter and not matter. This is the world that is possible and open now. And the thing that I get the most anxiety about is just kind of all getting in line to be able to do it, because it's now siloed in a whole different way. You have tech people, you have engineer people, you have investor people, and you have medical. It's a whole nother new world of silos compared to what it was when I was doing Target Cancer podcast, which is just different institutions versus community, specialists versus not. Now you have tech innovation. I mean, it's just going to take an army, and it's going to take all of us being networked together. But I think it's just unbelievable what we could very easily not only see in our lifetime, but even in the next decade if we do it right and get together on board fast enough.
It's amazing with AI, right? So the most prolific breast surgeons do what, maybe 200 surgery, like 200 surgeries a year. If you can bring an AI into your operating room, you can have thousands worth of surgeries worth of experience, like built into your tool that's right beside you. No matter how prolific you are, you're never going to get that kind of experience under your belt. Now, you've got tons of other experiences that the AI doesn't have, of course, but just having that as your assistant standing beside you or sitting beside you, running in some computer chip somewhere, it's amazing. It's amazing, right?
It's phenomenal. It's like, why wouldn't you?
Yeah. And so, this is just like so, and I think this is what gets me super excited, right? Like being able to, after having been in the AI industry for 10 years or whatever it's been at this point, right? Like moving this tech into a place where it can help everyday people. And then, like I'm just one lowly engineer from, moving from the tech, the computer world into the health world, but being able to like maybe move a few others of those engineers over, and eventually many, many more will come, I'm sure. It's super exciting to be able to kind of trailblaze that. And, who knows what's going to come from this, right?
Yeah.
Bringing these different, like you said, these different disciplines together.
Yeah.
I can't even imagine where we're going to go.
Yeah, I probably do the unhealthy version, which is every day delay that it takes from as optimally soon as it could be, patients suffer. Like that's how I think, which is probably just not healthy. But I'm just like, every day that's longer than needs to be is a stressor, because it's like it has direct, people and effects and individuals. So anyone listening, I don't want you to be discouraged. Just like we just full court press, like the internet has really opened up accessibility and reaching and finding these things. And unfortunately, a lot of it does take empowerment on the patient side and the loved ones taking care of them, which I think AI in its own right is going to help a lot in that capacity. I'm biting my tongue because there's a couple, but I just have to be careful. But anyway, we're getting there. So Adrian, this was a wildly exciting and informative and encouraging, interview. Just like to hear someone impassioned on something that's going to have huge outcome economically, psychologically, and most importantly, or not maybe psychology, clinically, is super exciting.
Yeah. Thanks for having me. I'm glad to, happy to come here, talk about what we're doing. I think what we're doing is really important and impactful across all those dimensions you said. And so for me, the more people I can hear about and just understand that this is available, right, is important, because, I believe in what we're doing. The team, we got an amazing team, in the company. Everyone's pushing to get this out as much as possible. So thanks for having me. I really appreciate you giving me the opportunity to talk about this with your audience.
Yeah, of course. I'm so glad.